Thank you for listening to my case study presentation. My name is Marissa Lewis. Today I'll be discussing the nutritional management and clinical care of a 90-year-old dialysis patient that I worked with during my long-term care rotation in Tupelo. His name has been changed to Jerry to protect his identity, and this case did not only deepen my understanding of nutrition and chronic disease, but it also allowed me to apply my research knowledge in a real-world clinical setting. Jerry is a 90-year-old Caucasian male weighing 154.6 pounds and about 70 kilograms with a height of 5 feet 6 inches. His BMI is a 23.5, which falls within the normal range. Jerry was receiving at-home hospice care for chronic back pain before his condition worsened, which led him to a hospital visit, which then eventually led to admission to a long-term care facility. Jerry's medical history is complex and includes several chronic and acute conditions: chronic kidney disease, stage 3, acute kidney failure dependent on dialysis, type 2 diabetes, anemia due to kidney disease, hypertension, dysphagia, and a stage 3 pressure injury. He also was diagnosed with a lung and ureter cancer. He has hypothyroidism and high cholesterol and major depressive disorder. Socially, Jerry was living at home with assistance before admission and currently resides in a long-term care facility for dialysis and PEG tube management. Jerry's medication list includes levothyroxine, pravastatin, amlodipine, mirtazapine, and sertraline. Each of these come with nutritional concerns such as not being able to take calcium or iron, avoiding grapefruit, increased appetite and weight gain. Also, some of these medications can influence sodium and hydration balance. Jerry's weight is 154.6 pounds. His height is 68 inches. His calculated ideal body weight is also 154 pounds, which gives him the ideal body weight percent of 100, indicating that he is at his ideal weight, although he still is considered moderately malnourished due to other factors like muscle wasting and fat loss, which is all noted in his physical exam. Jerry's following a regular diet with a mechanically soft texture and thin liquids, along with PEG tube feedings. His PEG tube is scheduled, and that includes a 2-cal formula at 50 milliliters per hour for 18 hours per day, which this provides 1,765 calories, around 74 grams of protein, and 1,628 milliliters of water. His oral intake is low, but he's receiving about 704 calories, 32 grams of protein, and that is daily, which he's only meeting with that oral intake 41% of his energy needs, 43% of his protein needs. And he also experiences the feeling of being full quickly, which has shown to limit his intake. Jerry's lab work show a mixture of stable and concerning values. His creatinine and BUN are elevated, which can indicate his impaired kidney function. His albumin is low at a 3.5, and he has anemia with low hemoglobin and hematocrit levels. his phosphorus and potassium are slightly low, which may reflect the dialysis related nutrient loss and intake issues. For energy needs, I use the Mifflin St. George equation with a 1.3 activity factor, estimating about 1,730 kilograms per day. The protein need ranges from 70 to 88 grams per day, and fluid needs are about 1,750 to 2,100 milliliters. While his PEG tube feeds meet most of these needs, his oral intake isn't sufficient. So we had to strategize ways to increase nutrient delivery without overwhelming his digestive tolerance. During the NFP, Jerry exhibited signs of mild fat loss in the buccal areas and muscle wasting in his temporal and clavicle regions, indicating moderate malnutrition. These signs align with his low intake, poor wound healing, and dialysis-related nutrient depletion. Jerry's nutrition diagnosis is inadequate oral intake related to decreased appetite, reliance on PEG tube feeding, and metabolic demands for dialysis, as evidenced by unintentional weight loss, moderate malnutrition, and insufficient protein and energy intake. Our interventions include continuing the PEG tube feedings with his 2-cal at 50 milliliters per hour for 18 hours, monitoring his tolerance with that, and offering a regular diet with mechanically soft textures and thin liquids. We also honor Jerry's food preferences, supported meal and tube feeding assistance, and coordinating with the dialysis dietitian to recommend nocturnal feedings for a better nutritional coverage. And we are closely monitoring his weights, tube feed tolerance, percentage of meal intake, signs of any GI distress, and all relevant labs, whether that be his kidney labs, his blood counts, and all of that. So far, Jerry has shown improvement weight stability and better tolerance to his PEG tube feedings. We've made several feeding adjustments, and currently the regimen appears to be working very well for him. And then here is just some of the research that goes behind all of our reasoning for his PEG tube and being on dialysis, all while accommodating his renal function. So from this first resource, malnutrition is highly prevalent in dialysis patients and linked to poor outcomes. Inflammation can worsen, protein, energy wasting in CKD patients. Nutrition interventions can reduce hospitalizations and improve quality of life. With the second resource, advocating for individualized and patient-centered nutrition care with a patient with CKD, recommending regular monitoring and intake and labs and body composition, just being very key to this specific patient, emphasizing aligning nutrition plans with patients' treatments and goals and all their preferences on that third reference. Protein needs increased in CKD patients on dialysis to prevent catabolism. Careful fluid and electrolyte balance too is essential, especially with multiple comorbidities. Overall restricting diets may lead to undernutrition and malnutrition. And in that last reference, adequate protein, vitamin D, zinc are all essential for wound healing and immune function. Malnutrition impairs healing and increases infection risk, especially with his pressure wound. That was a big key factor and where it got kind of hard with the proteins in his renal labs and just balancing all of that out. And then nutritional support can improve post illness and post surgery recovery. And thank you for listening and taking the time to look over my presentation. I am grateful for this opportunity to share this story and what I've learned from Mr. Jerry and being able to work with a dietitian down in Tupelo and just being able to be a dietetic student. So yeah, thank you.